Hi, this is Dr. Matthew Peluso, owner of Peluso Orthodontics with locations in Wayne and Cedar Grove, New Jersey. And today I'm here to speak about early orthodontic intervention and evidence-based review. Our offices are located, like I was saying, in Wayne and in Cedar Grove, New Jersey. Our website is www.usabraces.com. If you'd like to reach us or have any questions or comments, please feel free to reach out. The American Association of Orthodontists recommends for orthodontic checkups no later than age 7 for children. This is due to the fact that we can identify some issues early on that can be rectified and would benefit the patients long term. This is just an example of some of the problems to watch in a 7-year-old. This is some literature put out by the American Association of Orthodontists. You could see that some of the issues that we can address early are cross bites, both anterior and posterior. We could address crowding, open bites, protrusions, ectopic eruption of teeth, jaw discrepancies such as class 2 and class 3 malocclusions, diastemas, and digit habits and other oral habits. So just go over a brief outline. We're going to first have an introduction to phase 1 orthodontic treatment. Then we'll review patient selection and examination, followed by common indications for phase 1 orthodontic treatment, treatment techniques and procedures. Then we'll speak about monitoring and follow-up, and then we'll review at the end. So phase 1 orthodontic treatment refers to the treatment of the early intervention for children, typically between the age of 6 and 10 years old. The purpose of this treatment is to address specific dental and skeletal issues at a young age to prevent more common complex problems in the future. It may involve the use of appliances to guide jaw growth, create space for incoming teeth, extraction of primary teeth, or improving the alignment of existing teeth. Early treatment can lead to better outcomes and may reduce the need for more extensive orthodontic treatment later in life. The importance of phase 1 orthodontic treatment lies in its ability to identify and correct the developing dental and skeletal problems early. So early identification of these issues is key. By addressing these issues at a young age, orthodontists are able to guide proper jaw growth and tooth alignment, reducing the risk for more severe complications later on. Early orthodontic intervention can also lead to more favorable outcomes, potentially shortening the duration of and complexity of future treatments, and improving the overall oral health and aesthetic appearance of the patient. One common text that very popular in orthodontic residencies is the text by Jim McNamara, Orthodontics and Orthopedic Treatment in the Mixed Dentition. This text talks about many different treatment techniques that we can use to help rectify these early orthodontic issues. The key is really patient selection and identification of these issues. The criteria for identifying candidates for phase 1 treatment and timing considerations are usually comprehensive examination, dental and skeletal assessment, evaluation of growth and development, and functional considerations. Comprehensive orthodontic evaluation is comprised of assessing the alignment of the teeth, if they're crowded, spaced, misaligned, bite relationships, which are noted as overjet, overbite, and what angle classification the bite is, class 1, class 2, class 3. Noting the jaw position of the maxilla and the mandible relative to the skeletal base and also relative to each other. Facial photos are very helpful to identify these and to document these different discrepancies. We often use panoramic and lateral cephalometric radiographs to identify position of teeth, presence of teeth, absence of teeth, and jaw relationships. We also use PA cephs, which also can show asymmetries in the jaw growth. More commonly, recently, the use of CBCTs in orthodontics help also identify these disharmonies and also position of unerupted teeth and also presence or absence of them. And dental models, stone or digital, are used to identify and make measurements, to identify tooth position, and to make measurements if there's crowding or spacing and how much and what where they need to be addressed. Here's an example of our patient exam card. This is a page that we use, that we record all of the different things that we see when we do our clinical exam on a patient. It includes both radiographic and clinical examination information and also our treatment plan. So the dental assessment and skeletal assessment, we usually use the panoramic radiograph to assess missing teeth, extra teeth, crowding, ectopic eruption of teeth. We also can visualize the root anatomy and detect any pathology such as cysts, osseous abnormalities, or anatomic abnormalities. We also use the cephalometric radiograph, like I mentioned before. We could see the anterior-posterior position of the maxilla, the mandible. We could also see the vertical position of the maxilla and the mandible. And we can compare these positions relative to the cranial base and also to each other. This is what we use to determine if the patient exhibits a class 1, class 2, class 3 skeletal pattern, and also to ascertain the vertical growth pattern of the patient. Like I was saying before, PA cephs are used, they're used to show a coronal view of the skeletal structures, and they're used to ascertain if we have any kind of asymmetries and where the asymmetries are present. Evaluation of growth and development, a very common and easy way to quantify where the patient is in their maturation, is using the cervical vertebral maturation method. We use the lateral cephalometric radiograph to ascertain the growth, what growth stage the patient is in. And it does help to classify the maturation based on the morphology of the specific cervical vertebrae, particularly C2, C3, and C4. We can see that we use this to predict the timing of growth spurts, which aids in the planning of orthodontic treatment, especially for intervention related to growth modification. So here is a representation of this cervical vertebral maturation method. So we could see that when the C2, C3, and C4 vertebrae are getting these cupping at the inferior border, that helps us to determine when the maximum growth velocity is actually happening. So usually it's between on an average between 10 and 12 years old. And it's usually CS3 or CS4. So that's what we could use to kind of pick when the right time to intervene with orthodontic treatment. So we could see here, again, C3 and C4, ages 10 to 12 is usually when we see peak velocity. That's when we have the best chance to influence growth, direction, and potential using orthodontic treatment. Functional habits that should be considered are digit habits, tongue habits, and breathing issues. So digit habits, we usually can help the parents come up with different plans on how to stop these digit habits. And as far as tongue habits go, we see a lot of tongue thrust habits in the office. They can cause changes to the shape of the maxilla and mandible, and also constriction of the arches, which causes dental crowding and breathing issues. Some breathing issues are manifested by craniofacial syndromes, such as Pierre-Robin, which make it just harder for the children to breathe. Maxillary and mandibular hypoplasia, underdeveloped maxilla or mandible, also decreases the airway, so that makes it a little harder for children to breathe. Patients with cleft lip and palate also exhibit breathing issues, and patients with nasal obstructions, such as nasal polyps, can block airflow and cause breathing issues. So these are things that we have to identify during our examination. So common indications for phase 1 orthodontic treatment and treatment techniques. One of the things that is a common indication is tooth size arch length discrepancy, otherwise known as crowding. This is when the teeth are so crowded that they cannot erupt properly, leading to potential future complications. Bite or occlusal discrepancies, such as cross bites, when the upper and lower teeth do not align correctly when biting down. This can also affect jaw growth and direction, and also function. Ankylosed teeth, primary or secondary teeth that are fused to the bone and fail to erupt. Early loss of primary teeth. When we lose primary teeth early, they can disrupt the normal eruption pattern of the permanent teeth, requiring early intervention. Ectopic position of teeth is when the teeth grow in a non-ideal position, and they could potentially affect the adjacent teeth. Jaw growth issues is another common indication, where the jaws are misaligned, and the growth of the jaws may affect facial aesthetics and function. And also airway issues. They can cause poor growth and development, behavioral problems, learning difficulties, and cardiovascular problems. So we'll first talk about tooth size arch length discrepancies, otherwise known as crowding. So when the teeth are crowded, they cannot erupt properly, leading to future complications. This presents in the dentition as overlapping teeth, could possibly also present as cross bites anteriorly or posteriorly, or in lack of generalized spacing in the primary dentition is a big early indicator. So here's an example of some dental crowding on the upper and lower. So like we were saying, lack of generalized spacing in the primary dentition is an indication of future crowding. There should be about 6 to 8 millimeters of spacing in each upper and lower arch in the early primary dentition. If you see, like on the bottom picture here, no spaces between the primary dentition, that's usually an indication that there's going to be crowding later on, and there's not going to be enough arch length to fit all the teeth in. Causes of crowding are genetic. You could have small jaws and bigger teeth. Also, redundant frenum attachments can cause crowding, and different habits also, such as digit habits. Treatments for tooth size arch length discrepancies include fixed expanders, such as the upper Hyrax expander or Haas expander. They're all in the lower fixed spring jet or lower fixed lower expansion appliance. In our office, we use the upper Hyrax quite commonly, and the lower flea or fixed lower expansion appliance. You could also use removable expanders such as sport plates. You can use also limited braces. and also use frenectomy procedures. Here's an example of a maxillary hyrax appliance. It's a tooth-borne appliance that is adjusted and it will actually expand the palatal suture. Here's an example of a lower expansion appliance that is spring-loaded, and this would widen the lower, again, tooth-borne. Here's examples of removable expander appliances with little jack screws in the middle. These are should be worn as much as possible. People do take them out to eat and brush, but they should be worn all the other times. Here's an example of what we use in the office most commonly. We actually use 3D printed expanders here in the office. The upper is a Hyrax appliance. The lower is a lower fixed lower expansion appliance, or FLE. They both have expansion screw mechanisms in the midline, and we're able to get expansion of both arches. I like the 3D printed ones because they fit very well. They also do not need spacers to be placed, so they're very comfortable for placement, and they work extremely well. Maxillary expansion can be beneficial even in the absence of a crossbite. So this is something that is, I guess, a little not recognized by all practitioners, but even in the absence of a crossbite, maxillary expansion can be indicated. It can improve the dental arch width, enhance airway function, and promote proper occlusion. Studies indicate that it can help with crowding, improve aesthetics, and the overall support of oral health. The specific indications for maxillary expansion without a crossbite may be varied based on the individual patient assessment and treatment objectives. So here's just some a literature review of advocating expansion in the absence of a crossbite. And if you have any questions, please feel free to reach out to me. Mandibular expansion is also very popular and is a viable treatment option for people with crowding in the mandibular arch. You can use fixed or removable expansion appliances to achieve width increases that are stable. The arch width increase is the result of uprighting of the buccal segments. Lower increase in arch width is not a new idea. Functional appliances that were very popular in the 60s and 70s, such as the Frankel appliance or lip bumper, really worked on the same premise that you can widen the lower alveolar bone in the mandible to get uprighting of the lower teeth, which would increase arch circumference, which would give you more room for the teeth. Here's an example of one of those appliances from the 60s and 70s called a Frankel appliance. What it was plastic shield that allowed the pressure of the cheek and the lips and the tongue to be taken away from the teeth to allow them to expand naturally on their own. Here's an example of a lip bumper. So what this would do is this was a lower appliance, bands on the lower first molars, and this bow that sat up against the lower lip. And the idea was that you were going to shield these teeth from the pressure of the lips and the cheeks and actually allow the teeth and alveolar bone to upright and widen. Mandibular expansion in children. It can be spontaneous. There's different articles that support that. And that's how the premise of the older appliances, the lip bumper and the Frankel appliance, worked on. So here's an example of a case. We have both lower and upper constriction. When we look at the panoramic x-ray, we could see that the permanent canine and premolars, both in the upper and lower arch, do not have enough room to erupt into the mouth. So these are indications for expansion treatment early. So using an upper Hyrax and a lower fixed lower expansion appliance, we were able to expand both the upper and lower jaws. Well, we were able to expand the upper jaw and to upright the lower dentition and expand out the alveolar bone on the lower. And we were able to gain more arch circumference, arch length, to allow the teeth to fit in. Here's another example. We could see on the panoramic x-ray, very crowded, unerupted canines and premolars. And when we look in the mouth, we see that there's so much crowding that the upper lateral incisors aren't able to erupt in. So by doing the expansion, we're able to create more room top on the upper and lower arches. Here's another example where the upper canines do not have enough room to grow in, but we made enough room for them. So now when we're done with our expansion, when the upper primary canines exfoliate, we'll have enough room for our permanent canines to grow in. Here's another case. When we look here, the lateral incisors do not have enough room to grow in. The upper canine and premolars, again, jumbled on top of each other, do not have enough room to grow in. So doing an upper expander, we were able to widen the upper palate and make enough room for the lateral incisors to grow in, and we made enough room for later for the canines to improve in position and grow in. So we could see how the upper permanent canines had no space to grow in, and then after the expansion, there's definitely more space for them to grow in. At this point, we would follow the patient and make sure that the primary canines exfoliate in a timely fashion so that the permanent canines can grow in. Next, we'll speak about bite or occlusal discrepancies, such as cross bites. This is when the upper and lower teeth do not align correctly when biting down, which can affect jaw growth and function. It presents in the dentition as single tooth cross bites or multiple teeth cross bites. They can happen in the anterior or posterior, both unilateral and bilaterally. The causes of these occlusal discrepancies could be genetic. Inherited traits can predispose individuals to misalignments in their jaws or teeth. Could be dental development also. Irregularities during the growth of the teeth can lead to improper alignment, resulting in crossbites. Environmental factors such as thumb habits, any other digit habits, mouth breathing, or prolonged pacifier can affect the position of the teeth. Also, trauma or injury can impact the teeth or the jaw, and causing misalignment and subsequent bite issues. Here's an example of a unilateral posterior crossbite. Whenever we see crossbites, it's definitely indicated to correct them. There are age limitations on when palatal expansion can be performed. Once the palatal suture is calcified, we're not able to use a tooth-borne palatal expander to gain arch circumference or arch width. For girls, that's usually around about 14, 15 years old. For boys, it's more like 15 or so. So we do have age limits when these appliances can be used and this treatment could be performed. That's why it's very important to identify it early on so that we can intervene early to get the best result possible. Here's an example of a single tooth or anterior crossbite of tooth number 8 and 9. Here's an example of a bilateral posterior crossbite. So we could see that the upper teeth are located palatal to the lower teeth on both right and left side. Treatments that can be used to help correct these occlusal discrepancies are fixed expanders, such as the Hyrax, lower flea. We could also use Schwartz plate expanders, limited braces, or frenectomy procedure. So here we have, and we could also do a combination of those treatments, such as expanders with limited braces. So here's an example of a case of crossbite. And after expansion and limited braces, we're able to correct the crossbite and get more arch development and better spacing. And this long term allows more room for the permanent teeth to erupt. Ankylosed teeth are primary or permanent teeth that are fused to the bone and fail to erupt normally. These teeth occur when a tooth becomes fused to the surrounding bone. Now, the only way to identify an ankylosed tooth is histologically, or if you try to move the tooth and it doesn't move. So those are two different ways that we look at, we can check the teeth. Again, histologically really won't help us. That means that we would have to take a tissue sample of the root of the tooth where it's fused. So we have to try to move the tooth, or we see it fail to erupt. That's another indication. Usually identifying these teeth early is very beneficial so that we can help affect normal eruption of the adjacent teeth. These ankylosed teeth could cause problems for adjacent teeth or cause failure of eruption of teeth underneath them. So here's an example of a lower second premolar, lower second primary molar that is failing to erupt, is ankylosed to the possibly ankylosed and would require extraction. Other causes, so the causes of ankylosed teeth, some are due to trauma. After trauma, inflammation and can form around the root of the bone of the tooth in the bone and cause fusion between the root of the tooth and the adjacent bone. Also, infections such as periodontal disease can compromise the attachment of the tooth to the bone. Developmental anomalies also can contribute to the ankylosis of teeth, and genetic factors. So treatment of ankylosed teeth, one mode of treatment is simply monitoring. If the ankylosed teeth is not causing significant problems to the adjacent teeth, they could be monitored and left alone. And then if they do start causing issues for adjacent teeth, they can be extracted or addressed at that time. Another treatment for ankylosed teeth is extraction. If the tooth is causing pain, misalignment, or other dental issues, extraction could be necessary. Orthodontic treatment can be employed if the tooth is still functional and positioned well. We can leave the adjacent teeth around it and straighten those while leaving the ankylosed teeth in position. Also, restorative options can be employed, such as implants or bridges that can be used to restore function and aesthetics. Surgical intervention for severe cases may correct with the reposition of affected teeth or the surrounding structures. This is less common, but is a viable treatment option. Identification of ankylosed teeth early on is very important to avoid potential damage to adjacent teeth. Could also The ankylosed teeth could also cause occlusal effects or super eruption of the opposing dentition, and also would result in negative aesthetic effects on the teeth. Another thing that we consider early is early loss of primary teeth. This is premature loss of the baby teeth can disrupt the eruption pattern of the permanent teeth, requiring early intervention. Causes of early loss of primary teeth could be due to dental caries, which lead to the premature loss, especially if they're not treated promptly with a restoration. Trauma or accidental loss of primary teeth is another cause of early loss. Congenital conditions where patients are developmentally missing teeth. Periodontal disease of the gum tissues could also affect the primary teeth, leading to early loss. And another cause would be malnutrition. A lack of essential nutrients can weaken dental structures, making teeth more susceptible to decay and loss. So here is a visual representation of the development of the human dentition. This is really good. I have this hanging in my office. It was given to me by the person I bought my office from, Dr. Solomon. It shows around the average age when we would expect to see the primary teeth and permanent teeth in the dentition. It gives us a general idea of the sequence and the age. Now, these are just average ages, which means that half of the patients could be before those ages and half after those ages. So I wouldn't worry. It's a good rule of thumb to use the ages that are indicated, but more importantly, the sequence and the development of the teeth in the certain sequence is really important to understand to help determine when and if early orthodontic intervention would be indicated and when it would be helpful. So early loss of primary molars are the most common teeth for which space maintainers are used. So if we lose primary molars early on, there are appliances that can be glued in that may help maintain the space for these molars. Primary canine loss early on can result in space loss or misalignment of the permanent teeth in the anterior. Premolars, when the primary molars are lost, if the primary molars are lost prematurely, space maintainers help preserve that space until the premolars grow in. And as far as the incisors, it's less common that space maintainers would be used in the incisor region. But again, it is determined on a case-by-case basis. Things to consider with the early loss of primary teeth are movement of the adjacent teeth. If a primary molar or canine is lost, adjacent teeth can drift into the space, leading to misalignment or causing not enough room for the permanent teeth to grow in later. It could influence eruption timing. If the tooth isn't if permanent tooth is not expected to erupt it soon, space maintainers definitely have to be employed to keep the space open. If we lose multiple teeth, especially molars, maintaining the space becomes critical to ensure proper dental arch development. And also potential for future orthodontic issues. Preserving space can prevent more complex orthodontic treatment later, as misalignment can lead to a crowding in the dental arches. So it's really important to if a child needs to have primary teeth extracted early, or if they are exfoliated early, or if they are lost due to trauma, it's really important to consider if we need to and when we need to maintain the space that tooth would hold to help facilitate the eruption of the permanent teeth to grow in later. This is important because if the permanent teeth or the other primary teeth that are in place are left to drift into that space where the tooth was lost, it can cause a lot of problems for the erupting teeth later and could cause the need for more extensive orthodontic treatment in the future. So like we touched on before, treatments for early loss of primary teeth are space maintainers. These are devices that are glued in that into the teeth that can help keep and maintain space for permanent teeth to erupt later. Also, restorative treatment such as fillings or restoring damaged teeth, stainless steel crowns can help prevent further loss of primary teeth. Braces and appliances can also help early on to regain the space necessary um, to help align and make room for the permanent teeth to erupt later, so that we don't have that arch length loss or space lost. Some examples of space maintainers. This is a band and loop. This is usually used if there's a single tooth that's lost unilaterally. Depending on the position and depending on the adjacent teeth, we can use a band and loop to hold the space open. And we leave that space maintainer in place until we see evidence of eruption of the permanent teeth. Here's some examples of bilateral space maintainers. On the top, we see a lower holding arch. On the lower left, we see a Nance TPA or transpalatal arch, and then on the lower right, we see a Nance appliance. These appliances are used to keep arch length and to prevent drifting of the teeth into that area where we did lose the tooth prematurely bilaterally, which is nice. So if we have multiple in one segment and there's not enough, if there's too much room to put a band and loop and the arm of the band and loop would be too big, we use a bilateral space maintainer, which is more efficient. Another indication is ectopic position of erupting teeth. This is when teeth fail to grow into the dental arch and or they do not grow into their proper position. The most common teeth that grow in ectopically are the upper permanent first molars and upper and lower permanent canines. So here's an example of a panoramic x-ray. If you could see tooth number 3 and tooth number 14 are growing in ectopically, and so is tooth number 19 and tooth number 30. So you could see how the mesial cusp is growing underneath the primary second molar in all 4 quadrants. That is caused by the first molar growing in ectopically. It causes resorption of the root of the primary second molar, and that causes that primary second molar to be exfoliated earlier than it should. And if that happens, the first molar drifts too much forward and will block the eruption path of the permanent second premolar. So this is an indication for treatment early on. Here's a close-up example on a bite wing. We could see that the permanent first molar is erupting into the primary second molar root, causing resorption of the primary molar root. If this is left untreated, we're going to lose or exfoliate the second primary molar too early, and we will have to maintain that space so that the second permanent premolar will have enough room to grow into. And if this is left unattended, we would have to actually regain that space at a later date. So some of the things I use in the office, this is kind of my go-to for a ectopically erupting first molar, is a de-impactor spring. It's a little spring that's a little metal spring that is bent up, that these 2 arms go subgingivally between the 2 teeth that we want to upright, and we activate it by using a special plier on the longer piece that connects the 2 loops. And what that does is it kind of squeezes the teeth together and it distalizes the permanent first molar so that it could erupt normally. Another appliance, if you can actually get this attached to the teeth, is a distal jet appliance. This is a cemented appliance with little springs that can help distalize teeth to help push them back. So if we did lose a molar prematurely. Now, the other most commonly ectopic erupting tooth are the upper and lower permanent canines. This is really commonly seen. This is something that we see in our office every day that can be identified early, and early intervention can really make a huge difference for the patient and decrease the amount of treatment that they would need in the future. So it's very easy to see by taking a panoramic radiograph, which is part of our initial examination. We're able to visualize the permanent canine and its position relative to the permanent lateral incisor. So you see these lines here. So basically, once the tip of the permanent canine crosses over the distal aspect of the root of the lateral incisor, there's a very high chance that the permanent canine is going to become impacted. So when we see that, we can it is an indication for early intervention. So there's many different indices that are used to identify this. There's many articles that quantify when that canine tooth is erupting ectopically, but basically they all really say the same thing, that once the tip of the permanent canine crosses over the distal aspect of the permanent lateral incisor root, there's an indication for treatment, and that there's going to be a high probability that the permanent canine will be impacted. So treatment for, if we identify those early impactions, treatment would involve upper or lower or upper and lower expansion to widen the dental arches to make more room for the canine to grow into. It could also indicate the need for early braces in the mixed dentition to help move the lateral roots away from the crown of the permanent molar, and also extraction of the primary canines to help facilitate the permanent canines to grow in a better position. Early expansion and extraction of primary canines allow normal eruption 68% of the time and help improve permanent canine position 94% of the time. So many studies show that this is definitely a treatment, or a way that early intervention can help limit the need for more extensive treatment later, and it makes a huge difference in the facilitating the normal eruption of the permanent canines. So here's an example case. So when we look at this panoramic x-ray, we can see that the permanent canine is overlapping the root of the lateral incisor. Now, this is a two-dimensional picture of a three-dimensional object, so we have to keep that in mind. So the canines are more typically palatally located, meaning that the crown of the permanent canine is palatal relative to the root of the permanent lateral incisor. Here's another example of an impacted tooth, but this is a central incisor. So when we look here, we see that the central incisor, tooth number 8, failed to erupt. When we look at our radiograph, we see that it's ectopically erupting, and definitely early orthodontic intervention is needed. So we can see the tooth on the lateral ceph, how high it is, and the angle that it's growing out. Instead of growing out vertically, it's growing out more horizontally. So early orthodontic intervention would include expansion, some limited upper braces, and also exposure of the tooth, meaning that we have a brace put underneath the gum so we can help put traction on the incisor to help bring it down into the dental arch. So we were able to bring this tooth down, but in order to do this, you have to identify these things early. So you're looking for, an abnormal eruption pattern or a tooth that should be there that shouldn't be there. So that's when we would explore with with some radiographs to see what's going on. Here's another example. By doing expansion, we made room for the canines to grow down. So this brings us to jaw growth issues. Concerning so jaw growth issues concerns about the alignment and growth of the jaws that could affect facial aesthetics and function. They present as overbites, which the upper teeth are significantly overlapping the lower anterior teeth, often due to the upper jaw being too prominent or the lower jaw being too retrognathic or too far back. Underbites um, are could present also as an underbite, um, which happens when the lower teeth are protruded beyond the upper teeth, indicating a discrepancy in the jaw. It can also present as a crossbite when the upper teeth are inside the lower teeth. And it could also present as an open bite. And this is characterized as a gap between the upper and lower teeth when the mouth is closed, often due to habits like tongue or digit habits or prolonged pacifiers. These issues can affect a child's ability to chew, speak, and may lead to self-esteem issues if not corrected. Some of the causes of these jaw growth issues, primarily genetic. Family history can play a significant role in determining jaw size and alignment, leading to hereditary conditions. So when we meet patients that have jaw growth issues, we always ask a family history, if other people in the family, in the immediate family, were affected by the same, just to give a little insight into if it could be genetic or not. Another cause could be thumb sucking. Prolonged use of thumb or pacifier can cause differences in jaw growth and position, which can lead to problems with function also. Mouth breathing is another issue that can cause a jaw growth disharmony. Breathing through one's mouth instead of the nose can alter the development of the jaws and the facial structures, leading to dental issues. And also misalignment of teeth can also cause jaw growth issues. They can cause pressure on the jaw and could also influence its direction of growth and amount of growth. So those are things definitely to take into consideration when a patient presents with misaligned teeth. So this is an example of a cephalometric analysis. This is a very basic one, but we use a lateral cephalometric radiograph to do measurements relating the cranial base to the upper jaw and the lower jaw and the upper and lower teeth. So we're able to see the anterior posterior skeletal patterns and quantify them by using the lateral cephalometric radiograph. We're able to see vertical patterns also. We're able to see the vertical pattern of both the upper and lower jaw relative to the cranial base. So an example of one of these discrepancies is a class 2 skeletal pattern. This is when the upper, it's a malocclusion, or the way the teeth and jaws aligned to each other is characterized by the position of the upper jaw being more forward than the lower jaw. This results in what we commonly see as an overbite, where the upper teeth significantly overlap the lower front teeth. Treatment that can happen early on to help guide the growth of these of the skeletal discrepancy are devices, functional devices such as the twin block or Herbst appliance that repositions the mandible forward to help guide growth in a positive direction. Headgear, which people commonly call a night brace, is an extraoral appliance which is attached to the upper teeth that helps restrict maxillary growth forward so that the mandible can catch up to it, or they could approximate each other better. Also, expansion appliances can be used to address skeletal discrepancies by widening the dental arch, potentially helping in a class 2 malocclusion. And also, space maintainers can help if early loss of teeth occurs. It can be used to maintain space for permanent teeth to ensure proper alignment later. So this is an example that I explain to parents a lot. So the arches, upper and lower, have to be coordinated. If the upper arch is too narrow, the lower arch would not be able to properly occlude with it. And this is easily done by using study models or even virtual digital models. You could approximate the teeth, fixing the overbite with the models, and you'll be able to see how the upper arch is usually constricted. So we give the example of a foot in a shoe. If the shoe is too narrow, the foot won't fit in the proper way where the toes are supposed to be up front. So if your upper jaw is too narrow, your lower jaw will not be able to slide forward enough and be in the correct position. Here's an example of a night brace. We really don't use this in our office, but this was commonly used, very popular back in the 80s, 70s, and 80s. That was to help restrict the growth of the upper jaw. This is a twin block appliance. So this is a tooth-borne appliance that is removable. And what it does is it has this 2 blocks of acrylic that form an inclined plane, which helps posture the mandible forward, hoping for some directional change in the growth of the mandible. So many studies show that the net result in correction of class 2 malocclusion is the same if it's done in 2 phases or just in 1. So in our office, we don't usually do early class 2 correction within certain parameters. So there are limits to what needs to be treated in early on, but there are a lot of studies out of North Carolina, UNC orthodontic department, that showed that early class 2 correction along with braces later gives the same net result as just doing class 2 correction later with just in the braces phase. So instead of doing an extra phase of treatment, we typically in our office, we're very selective on class 2 skeletal correction that we do early on. And like I said before, this is just an example of the landmarks of the lateral cephalometric radiograph that we use, that we're able to make measurements and quantify where and how much the jaws are misaligned to each other and to the cranial base. This is an example of a class 3 skeletal pattern where you can see the lower jaw is ahead of the upper jaw. Class 2 is usually when the upper jaw is ahead of the lower jaw. Class 1 is more ideal when they are actually approximated closely to each other. Class 3 skeletal pattern, often referred to as a class 3 malocclusion, is characterized by a jaw relationship where the lower jaw, the mandible, is positioned further forward relative to the upper jaw. This leads to what we see commonly as an underbite, where the lower teeth are overlapping and stick out past the upper teeth. Functionally, we do want to intervene early on if we see patients present with a class 3 skeletal pattern. Functional appliances such as the Frankel, like we showed you before, that help do encourage jaw growth in certain position. They help modify the direction of the jaw growth by taking pressure off the tissue pressure off of the teeth and the jaws to help them erupt and align better. We also see more orthopedic appliances, such as face mask therapy, used to correct class 3 skeletal pattern early on, which is used primarily in growing children to bring the upper jaw forward. We also see the use of palatal expanders, like I was explaining before. We want to approximate and make the jaws wide enough and coordinate them top and bottom. That's helped to improve the balance of the dental arches. And also retainers. In some cases, retainers can be used after initial treatment to maintain the achieved position of the teeth in the jaw. So at this time, I'll talk about class 3 face mask protraction treatment. This is something we do a lot in the office. It's early class 3 protraction face mask treatment. It reduces the need for orthodontic surgery later. It's an orthopedic treatment, meaning we're actually moving the bones of the face, and it's aimed at reducing and redirecting mandibular growth, so that we can actually reducing or redirecting the mandibular growth and enhancing the maxillary growth. So the goal is to have the upper jaw move forward. On average, we could see a 6 millimeter improvement in overjet, which is pretty amazing. So this is an example of protraction face mask therapy. So we would start first with an upper palate expander, such as a Hyrax expander, to widen the upper arch so that we can have enough room for the permanent teeth to grow in, and also help coordinate the upper and lower arches together, the width. Then we use this face mask, which is this bow attached by rubber bands to the upper expander. And what it does is it helps pull the upper jaw forward so that the upper jaw can move orthopedically, the whole base of the jaw in front of the lower teeth. The idea is to get the upper teeth in front of the lower teeth so that they can grow normally together. So here's an example of a case. We start with anterior crossbite, a lot of crowding. So we can see the upper arch is very crowded. There's not enough room for the canine and premolars to grow in later. And when we look at the lateral cephalometric radiograph, we see that the upper jaw is behind the lower jaw. At this age, the upper jaw should be either equal or in front of the lower jaw. After face mask therapy, this is the results that we're able to achieve. We're able to make the upper jaw wider and also bring the upper jaw, the base of the upper jaw forward so that the upper teeth overlap the lower teeth. And then when we look at the lateral cephalometric radiograph, we can see that the upper jaw is in front of the lower jaw. And here's a side-by-side example. So the common kind of sequence of treatment to fix this early on is usually upper expansion. We glue in the upper expander. We have the parent turn the expander mechanism for a month or two. After the width increase is obtained, we start the face mask therapy, wearing that bow in the house and while we're sleeping. Our treatment, the goal is to, for the best treatment, is to wear it 13 hours a day. Usually, if we wear it consistently for 13 hours a day, we wear it for 8 months total. If you wear it well, after 8 months, you will get the most amount of correction that you will be able to obtain. So it's really important for the patients to wear these consistently and well. Usually towards the last 4 months of that face mask therapy, we add limited upper braces on upper 7 to 10, teeth number 7 to 10, to help align them and push them forward a little bit more to help fix any underbite. Here's another example. Upper jaw is behind the lower jaw. crowded upper dentition. After face mask therapy, we're able to bring the upper jaw forward so it's more even with the lower jaw, and use those limited braces to get some overbite, positive overjet and overbite in the anterior. Here's another case. You could see class 3 molars on both sides, right and left, edge to edge anterior bite. When we look at the lateral ceph, the lower jaw is behind the upper jaw slightly, and we have a lot of crowding. So the upper canines do not have enough room to grow into. So we do upper expansion and protraction treatment with extraction of primary canines to help make room for the canine teeth and to help bring the upper jaw skeletal base forward. Now we'll speak about airway issues. Common causes of airway issues are enlarged tonsils and adenoids, also allergies, medical conditions such as asthma, and oral breathing habits. So those could be a sequela of the enlarged tonsils and adenoids, asthma, and allergies. These conditions may lead to orthodontic sequelae such as malocclusions, crooked teeth, dental crowding, or altered facial growth patterns. So airway issues can affect the way the jaws grow in young children. We could see that they have longer lower facial profile, narrow dental arches, and improper alignment of the teeth. Nasal obstruction causes, like I was saying, longer facial thirds. So you see patients where their chin is angled very down. We see class 2 malocclusions where the lower jaw is retruded and angled down more than it should be. This can also present as an anterior open bite when this lower jaw is angled down and open more. We see that the upper and lower teeth fail to overlap, and we could see narrow upper jaw. Orthodontic treatment recommendations often include early intervention strategies to address these airway problems. Treatment using functional appliances to promote jaw growth and positioning, expansion of the dental arches to improve airflow, and orthodontic braces to correct malocclusions are all different things that we can use to when we identify airway issues early on. Expansion can help open up the nasal passage and make it easier for the patients to breathe. Maxillary expansion is an effective treatment to improve nasal airway obstruction. And it's very easy, and it's better to do it early on. Like I said, there are time limits on when we could actually perform these procedures with these appliances. Once patients hit a certain age, we're not able to do the expansion. Another very important part of this early orthodontic intervention is monitoring and follow-up. So even if we do early orthodontic treatment, or we don't do early orthodontic treatment, it's important to follow up with the patients to make sure that their dentition is growing in a timely fashion, the baby teeth are resorbing, permanent teeth are developing, and we want to be able to pick the right time when and if comprehensive orthodontic treatment would be needed. So regular checkups to allow the orthodontist to track the progress of tooth movement, eruption, exfoliation, jaw growth. Also, we're able to identify any changes or failure to grow correctly. Sometimes patients are asked to wear retainers during this period of monitoring and follow-up between phases of treatment to help keep things that were corrected in the correct position so we don't have any relapse, and to also evaluate the development of the permanent dentition and determine if we need to extract any primary teeth if necessary, So sometimes we see an imbalance between the development of the permanent teeth and the baby teeth falling out. If a permanent tooth is developing normally and is ready to grow in the mouth, usually by exhibiting 2/3 to a full root of the tooth, that means that the permanent tooth is ready to grow into the dentition. If the primary tooth is not dissolving or resorbing in a timely fashion, it could be retained too long, causing a delay in eruption of the permanent tooth. These things can be identified early on. Ways that you can identify them are by looking in the mouth and usually by knowing when to the normal eruption sequence is. If we see that the patient exhibits an abnormal eruption sequence, it would be a good time to visit the orthodontist to determine when and if any primary teeth need to be extracted to help facilitate the eruption of the permanent teeth. In conclusion, early orthodontic intervention can result in correction of dental and skeletal abnormalities. Early orthodontic intervention can make future orthodontic treatment easier and shorter. By intervening early, we're able to fix issues early before they become a bigger issue. So this does help long term. It's important to identify aberrant dental and skeletal issues early so that orthodontic intervention can be initiated to help while the children are still growing. When in doubt, the like we were saying at the very beginning, the American Association of Orthodontists recommends the first visit to be 7 years old. So referral of 7 to 8-year-old patients to an orthodontist for evaluation is really the safest, easiest way to identify any of these early issues that can be addressed. I want to thank you for your attention. And if you have any questions, please call or text me at the office. My office number is 973-239-6300, or email us at drpeluso@usabraces.com. We'd be more than happy to answer any questions or to review any part of this lecture.